Great. So let's discuss the practical implementation and patient communication. We're going to talk about why you test, who you test, and how to ask for the test, the three most important pieces to get started. So why do you test? Well, let's look at that. In salivary testing, it's going to help us answer what type of infection do you have? Do you just have an oral infection that could be treated topically, or do you have an oral systemic infection and you need combination therapy, both orally and systemically? What's causing the infection? Probably one of the most important pieces. How severe is the infection? So not only are these pathogens there, but how much is there and who are they there with? And that's then again, the host response. How is the body going to actually help us fight these infections, or is it helping us fight these infections off? So salivary testing really answers these four core areas: the type of infection, the cause, the severity, and our host response. So important then in choosing the correct treatment for our patients. In fact, I want you to think of strep throat. Many of you have had strep throat, or you know people have had strep throat. You may say, hey, call the doctor. You make an appointment. The doctor says you still need to come in, right? They look in the back of your throat and they see the signs and symptoms. They see the big tonsils there. They see the white patches. They clearly see that infection. But what do? They still test. They still confirm what is causing this infection, what type of infection it is, right? Who's there with it, so that they can give you the right treatment. They're going to confirm that type of bacteria. And so they're confirming then that treatment plan and where to take the next step. They're going to do always that test. And so we're really following that medical model in testing, because if we don't take action and do the appropriate treatment, what does happen to strep throat? Well, we can get a strep rash, we can get the strawberry tongue, and we can get rheumatic carditis. Yes, that oral infection becomes systemic. And we're well aware of that, how important it is then that we do have to treat that systemic infection. Well, periodontal disease really is no different. But let's talk about, what if there's no signs or symptoms? Is it actually possible? Look at this patient. Yes, he has a history of disease, but many would argue that he might not have any activity. He's not active in periodontal disease. But how would we know? Does he even have an oral infection? What's causing it if he does? What type of infection is it? And what would be the best treatment? Well, let's take a look. Yes, just because we don't have the signs or symptoms, we still need to know if there's something microbially there. In fact, I would argue that about strep throat. There are many times that family members will go in and get swabbed or tested because somebody else had that strep infection, right? Even though they didn't have a sore throat or they weren't seeing the clinical signs or symptoms yet. This is that same process. And so we have to understand that these specific pathogens precede the inflammation. Then once that inflammation, it precedes the bone loss. So it is a pathway. We get pathogens, we get inflammation, and we get bone loss. That is a series of events. And we need to understand that clinically, in the beginning, in preclinical disease, we're going to have pathogens, but we don't actually see it. And that's because we're in that preclinical state, right? Once we do see that a patient has these pathogens, it's just a matter of time until we see the inflammation and then the bone loss. In fact, we've known that from our studies going back, and look here, it's from our Journal of Clinical Periodontology of 2008, reminds us why bacterial testing is important is because these red complex responsible for periodontal disease are there in as little as 1 to 3 millimeter pockets. So look on the left-hand side, you're looking at your pocket depth, and going across horizontally on the right, you're seeing these quartiles as they grow. And then we're looking at these red complex in red, we're looking at the orange complex, and we're looking at the green, the healthy species. What I want you to notice is that those red complex are there in as little as a 2.5 millimeter pocket. In fact, at a 3 millimeter is when we see that the red complex gets it into dysbiosis. It's actually now growing at a higher rate as those healthy species are falling off. In fact, we see that we're not even at a 4 millimeter yet, even between this 3.5, we have dominant red complex pathogens. It's not until later that we see the breakdown at that 4 millimeters. And so I say by time it's a 4, it's too late, right? It's already occurring. The disease is already in the process. And so we need to understand that. And that will really help you if you can understand that pathway. Then who do we test? And so, of course, just like strep throat, we want to test the people with the clinical signs and symptoms, right? These could be your recare patients, your period maintenance patients, patients with caries, active decay. This could be implant or surgery or mucositis patients, right? They're showing us clinical breakdown or things that are going on. But it can also be part of our assessments. And I say that's the most important patients to really be screening for that preclinical disease. That's prevention. That's where we need to hang our hat and make the biggest impact before the event happens and they lose the bone. So one of the easiest places to start with the who then do we test is new patients, right? It's just part of our baseline assessments. It's part of our examination where we're getting the clinical signs and symptoms, and now we're marrying it up with this technology to see what's actually there. And of course, we can't forget the third category in my top 3, which is the high-risk patients. These are systemic disease patients. Maybe they're having surgery, they're getting implants, they could be airway, they could be high medical risk, right? We want to be screening them, right? And making sure that their mouth is not putting them at risk. And so once we screen our patients, a lot of people are like, well, how am I going to ask for the test? So let's talk about how easy it is to ask for the test. I want you to look at this patient here. You can look at the perio-chart, and that to me is one of the best times. I love to use perio-charts or radiographs. So every time you do a perio-chart and you see the clinical signs and symptoms, right, we're going to use 3 easy sentences. So let's look at these 3 simple sentences. We're going to use the word problem and consequence in those first 2. So if we see bleeding, pocketing, we get to say to the patient, the problem is you have an infection not only in the tissue, but in the bone. The consequence of not treating this infection is it can continue to progress and get worse. And so the best solution is to start treatment today with a simple saliva test to find out how aggressive this infection is, and more importantly, the best way to treat it. So we can use those 3 sentences so easily with a perio chart. We can do the same thing with our radiographs as well. But what saliva testing really is giving us this advantage to move into better treatment decisions, that we can make the best decision for our patient and give them the health that they deserve. So I'm honored to be here with you and going through these. I do have these 6 protocols, so come and learn with us. And of course, please use your resources through Stella Life. They're there to help support you. Any questions that you have, your representatives can help you implement the products into these protocols. I look forward to seeing you on another module.